no disturbance now, so I can carry on. So this talk on ureteric reimplantation is basically addressed to a different group for juniors as well as people who are slightly in the higher end of learning the curve. I'm going to touch a little bit of about open ureteric reimplantation, which many of us still do, and then I'm going to tell a little bit about laparoscopic reimplantation. I'm going to talk on different types of reimplantations, all different types which I practice, and I'm also going to tell a little bit about the Megaureter and how to deal with it. The classical indications for ureteric reimplantation are breakthrough urinary tract infections, worsening of the renal scars, failed conservative treatment, particularly in an older child who is like 4 or 5 years old. And usually it goes like this: the medical management, and if the medical management has failed, or somebody has tried an endoscopic treatment, or they can go for a straight away surgical management. But basically medical management is tried in a case of vesicoureteric reflux as well as in the vesicoureteric junction obstruction, also known as primary obstructive megaureter. Classically, the reimplantation is classified as intravesical and extravesical, supratrigonal and infratrigonal. And the commonest one which is performed and taught by everybody is the Cohen's ureteric reimplantation. That is the infratrigonal intravesical reimplantation. Even I tend to do more of this, but I also do this Ledbetter reimplantation. The Ledbetter is extravesical reimplantation, and also Poli-Turner Ledbetter, which is an intravesical supratrigonal reimplantation. So I will show a video of all three different things, and when I do all those things. Again, these reimplantations can be performed open, laparoscopic, or robotic. I'll be covering open and laparoscopic. I won't be covering robotic in this lecture. Can all of them be muted by? Yeah, that's better. So ureteric reimplantation, the history and development of surgical techniques. This was one of the papers written much earlier. In addition to what I mentioned earlier, like Cohen's and extravesical reimplantation, there are reimplantations like Hutch and Gil-Vernet, which involved getting the ureter into the bladder or advancing the ureter towards the ureteric, the urethral opening. So these two reimplantations are kind of being done in several places. I mean, several times. Like for example, when we do a bladder extrophy closure, we tend to just bring the ureter and then make it come more into the bladder. Sometimes there is no tunnel, or that the submucosal tunnel, the mucosal tunnel breaks away. We just leave it there, cross it, and then or bring it closer to the urethral opening and then leave it there. The mucosa forms over it. So we do these kind of reimplantations without our knowledge these sometimes. And then these kind of intersusception of the ureters and this kind of nipple type of reimplantations, these also are now being done. For example, this Megaureter reimplantation, modified Shanfield technique, which I'll be showing later, is basically one of this kind of reimplantation. You intercept the ureter into the bladder or create a nipple. So although these are all historic reimplantation, they do stage a comeback from time to time when we operate on these children for different conditions. Now this is a slide given by Professor Ravikumar. Now there is a combined intra and extravesical reimplantation, which we do sometimes. So we go outside the bladder, dissect the ureter, tie it off close to the vesicoureteric junction, then make a new hiatus, create a new tunnel, and then bring back the ureter close to the native ureteric orifice. So this kind of reimplantation we typically performed in a neurogenic bladder during augmentation, or sometimes there is a failed sting procedure or failed reimplantation. You just don't want to mess around with that scarred site. So you go outside the bladder and then you tie off the ureter as low as possible, and then bring it inside, creating a tunnel between the mucosa and the detrusor. So this is a combined intra and extravesical reimplantation, which is also sometimes being done. Principles of ureteric reimplantation are essentially to prevent vesicoureteric reflux and to prevent obstruction happening at the place of a new anastomosis. So the adequate tunnel width ratio, what has been proposed and widely accepted, is 4 to 5:1. That is the width between the diameter of the ureter and the length of the tunnel. For example, if the width of the ureter is 8 millimeter, the length of the tunnel is going to be 3.2 centimeters. So this can be a mucosal tunnel, which is a progression of the ureter into the bladder, or this can be a subdetrusor tunnel where you open the detrusor and bury it between the mucosa and detrusor. And yeah, so the commonest reimplantation which is being taught and which is being done by everybody is Cohen's ureteric reimplantation. We all know the steps. It involves the mobilization of the ureter, creating a submucosal tunnel, and then crossing the ureter across. So I'll show you a little video for the sake of the juniors. This is an open reimplantation we particularly recorded for the purpose of the MCH trainees. So the bladder is opened in a vertical incision. The bladder is opened only in the inferior aspect. It is not open in the dome because you want to pack it with a couple of swabs there. So this retracts the dome, and then you leave a Dennis Brown ring retractor there. The ureters are cannulated with the feeding tubes. We take a stay stitch with usually catgut, and then we start mobilizing all around that ureter. Now I prefer the needle point diathermy to mobilize, but a lot of people use scissors to mobilize. So we then mobilize the ureter carefully without damaging it, and then we create a submucosal tunnel between the two ureteric orifices. Now before we cross the ureter, actually we may have to close the detrusor. Often at the level of the hiatus, you may need 1 or 2 sutures. So that is the closure of the detrusor muscle or the hiatus behind the ureter. This is a bit like lateralization of the cord structures during the hernia repair. So you make the hiatus go laterally so that you have more of a ureter mucosa entering and the mucosa there. The tunnel is more. So you have to close the detrusor behind the ureter, then cross the ureters, and then fix the ureters across. So this is anastomosis of the mucosa. I prefer to use a 5-0 Vicryl for this step, interrupted sutures. And there are a lot of ways people can stent it or tube it or leave an infant feeding tube. So that is how the finished Cohen's ureteric reimplantation looks during an open reimplantation. You remove the swabs and then close the bladder. And then now there are a lot of options here during a Cohen's reimplantation. This is something which every surgeon has got different practice. Some people leave an SPC, some people don't leave an SPC. If you leave an SPC, the ureteral catheter can be removed in 2 days possibly, and that is the main reason for the bladder spasms. And some people leave a double J stent. Some people leave the stent attached to the SPC so that when you pull the SPC after 7 days, the stent also comes out. Some people leave an infant feeding tube, which is coming out via the bladder into through the sides of the wound, and then that is taken out after 5-6 days. Then catheter, some people leave the catheter for 5 days, some people leave it for 7 days. The practice varies. And drain, that depends on again individual practice. Most often you don't need a drain. So that is about Cohen's reimplantation. Now coming to extravesical reimplantation. Extravesical reimplantation is typically performed for a unilateral vesicouretic reflux. You create a detrusor incision like a detrusor myotomy. If you are removing the distal portion of that obstructed megaureter, then you may have to anastomose the ureter. But in a case of reflux, you do not have to disconnect that ureter. So you just bury the ureter and you bring out, make a detrusor tunnel rather than a mucosal tunnel here. So the principle is the same. The detrusor is closed over the ureter so that it lies in a submucosal plane. So that is again another open extravesical reimplantation we recorded for the sake of the postgraduates. I prefer to leave a ureteric catheter during cystoscopy, and I leave the ureter attached to the catheter, the urobag. That is the lateral umbilical ligament. When you go outside the bladder, you ligate the lateral umbilical ligament and trace it laterally, and that leads you to the vesicureteric junction. So that is an important mark, and we can see the ureteric catheter. The ureter is looped through the with a small vessel loop. We leave a Toomey syringe attached to the Foley's catheter so that we can distend the bladder partially during the procedure. So we have taken stay stitches on the bladder, and we are distending the bladder partly, and then the incision in the bladder or the to detrusor myotomy is exactly like a mirror image of where the ureter is inserting. So if the ureter is inserting at 7 o'clock, then the incision is towards 2 o'clock. So this is an incision in the detrusor muscle. You should be able to see the mucosa bulging there. So that is the mucosa bulging. And this procedure, when we do the laparoscopically, it's exactly the same. Only thing is, during open procedure, you have a nice control of these stay sutures, and you can readjust the stay sutures in such a way that after you have taken the detrusor tunnel, the stay can be placed in such a way that the ureter lies automatically in the tunnel, and then you can start suturing the detrusor. So often you need 3 to 4 3-0 vicarial sutures, interrupted sutures, to bury the ureter. Now, the advantage of an extravesical reimplant is you have the ureter in straight line. So the ureteric orifice is not crossed. So it is available for future access to the upper tract in the form of ureteroscopy if you need it. So that is available, and that is the big advantage of the extravesical reimplantation. Bladder spasms are less, the post-operative stay is less. The disadvantage is if you do it bilaterally, it can lead to retention of the urine. That is usually a temporary phenomenon. That is because we mobilize the ureter around the neurovascular bundle which occurs at the VU junction. Now we looked at the extravesical versus Cohen's reimplantation, our outcomes, and published in the Indian Journal of Urology. There is definitely less operative time, less patient discomfort, and less hospital stay with extravesical reimplantation. And in that particular study, we did 32 bilateral reimplantations, and we did not have any retention. The main reason probably is we have already modified this technique as described for the nerve sparing ureteric reimplantation. So the original ureteric reimplantation, they were mobilizing all around this entrance of the VU junction, whereas in the modified nerve sparing reimplantation described, the mobilization doesn't happen all around the vesicureteric junction. It happens at this point, it goes like this. So this is how the incision is. It doesn't go around, so but it leaves the portion of that the detrusor attached to the ureter. So that nerves which are running there are spared, and if that is the case, then it usually doesn't cause a problem with the urinary retention. Now, Poli-Turner Ledbetter reimplantation. The original Poli-Turner Ledbetter reimplantation was not a very great operation, in the sense we opened the bladder, but instead of doing everything under vision, what they did was they put a right angle or hemostat and then picked up the ureter blindly and then brought it up at a higher place, and then they made a tunnel from a higher end of the inside the bladder to the native place. So that was the original Poli-Turner Ledbetter reimplantation. It had a lot of problems like kinking of the ureter, obstruction of the ureter, and this also has been modified nowadays. So now we don't do it like that. So we do it like we mobilize the ureter, like we start mobilizing for Cohen's. But after that step, we put a hemostat under that area between below the detrusor, actually, not just the muscle, below muscle and the detrusor, and then we divide both of it. So once that is done, we lift the ureter up, close the detrusor below, and then bring back the ureteric orifice and close the mucosa. So everything is done under vision. So I will show you a video of a Poli-Turner Ledbetter reimplantation being done in an open case. So this is a 2-year-old boy who had recurrent UTIs, and this patient had a patelless ureteric orifice. Scarring was there, and this is what I was mentioning. So we make an incision cranial to the place where the ureter is entering. So this both the mucosa and the detritus are opened under vision, you will see vas difference. You have to make sure that vas difference is not damaged. This is important in both the Cohen's as well as extravesical reimplantation. You will see vas difference, and you have to make sure that you do not either damage it or divide it or take it in a bite. So that is opening of the mucosa and detritus cranially from the ureteric orifice. And once this is done, we will lift the ureter above, then close the detritus below. So this is the closure of the detritus below. And after this, the ureter has now moved cranially. So it is entering at a higher point. Then we bring back the ureter back to its native place, and then we close the mucosa over it. So here again, there is no crossing of the ureters. So the ureter access for the future upper tract is there. Now, I have not done this operation vesicoscopically, but this should be very much possible. I think experts like VVS and all should try this kind of operation laparoscopically also instead of Cohen's. Now, the choosing the types of reimplantation, I have been doing all three kind of reimplantations. Cohen's is something which I prefer for a bilateral vesicouretic reflex because both have to be dealt with, and it is easy to do. You cross it. So this is a Cohen's. And then unilateral vesicouretic reflex, I prefer Ledbetter reimplantation because it is much quicker in post-operative recovery with less bladder spasms, and it also gets you a straight access for the future ureteroscopy. And this Poli-Turner Ledbetter reimplantation, particularly I do in case of a obstructed megaureter or a vesicouretic reflux with a diverticulum or a ureterocele where you have to repair that area anyway. And in duplication anomalies, like where you do a common sheath reimplantation. So those are the conditions where I do this kind of Poli-Turner Ledbetter reimplantation. Now, coming to laparoscopic extravesical reimplantation, this is a 2-year-old boy who was positioned like this. Here again, we often do a cystoscopy and leave. I prefer to leave a ureteric catheter for 4 or 5 days. So that is the vast difference. You have to be pretty careful not to damage it. So in girls, you will see the broad ligament as well as the tubes and all. So you may have to dissect the ureter above that level as well as below that level. Once you dissect it above, then you will be able to see it, and then you should take it from the distal part of that distal to the broad ligament. But in boys, you don't have that problem. You just have to be aware of that vast difference. So the detrusor myotomy is done exactly in the same way, like how you do in the open reimplantation. The mucosal bulge is seen. So here again, you should have left the Foley's catheter with a syringe attached so that partly you can fill. Now here, the suturing is a little tricky in the sense that you have to go take a bite one side, go under the ureter, take the other side, then come back, then take it from this side and then suture it. So you advance the ureter one step at a time. So 3 or 4 sutures taken from distal to proximal, and then eventually it's a little painstaking process. And this is where this robotic has got a little advantage in the sense that you have your dexterity and movements and all are much easier robotically. But we are able to do it laparoscopically as well. So so you should start doing open extravesical reimplantation, get the hang of it. And then once you move to laparoscopic, it is definitely easier operation once you learn. You should also know how to use a backhand driving of the needle as well as taking a bath with. And then you take exactly like 3 or 4 sutures from distal to proximal, and then the ureter is buried. Now, this is an older boy, a 16-year-old boy, where I want to show you a different way I have done in this. Usually, we do it from distal to proximal, but in this patient, we put an extra 4th port to hold the ureter up. So this makes life much easier. So here again, the vas difference is there. So we have to, once you have to loop it in such a way that the vas is safeguarded and then taken away. So the vas difference is quite big in this adolescent boy. So this patient, again, we are taking a stay stitch in the bladder now. So we are making the detrusor incision. So that is the detrusor myotomy. And as we go distally, like in extravesical nerve sparing, we go here also like an inverted Y-shaped incision. We don't go all around, but distally we go like a Y-shaped. Here what we have done is because we have put an extra port to hold it, that is the vesicoureteric junction which you are seeing. So we have got an umbilical tape around the ureter, so we'll be able to hold it up from the lateralmost port superiorly. So once we are able to hold it up, we can start suturing from above to below or below to above. So in this patient, we have left it inside. So this is a different way of doing it. So we are doing it from top to bottom. So the suture taking is not like you go below, above, and then come back from below to above. You just do it from top to bottom. So only thing I have to warn you here is, if you want to do it this way, you have to make sure that the lowermost stitch is done. If you don't do the lowermost stitch, as you start from above, you may end up leaving a small diverticulum or recurrence of the vesicoureteric reflux. So as I said, I leave a ureteric catheter for 2-3 attached to the Foley's catheter, and then that comes out after 5 days. So coming to vesicoscopic reimplantation, vesicoscopic reimplantation is typically the Cohen's reimplantation, where you put the trocars right into the bladder through the rectus sheath and abdominal wall. You often do a cystoscopy, check everything, and then you fill the bladder, and you put a sound and then railroad the trocars. Now, one thing I want to tell you is, when you over distend the bladder, for example, like in this kind of situation, what happens is the bladder becomes an intra-abdominal organ. So you have a peritoneal fold here. So your port may actually go through the peritoneum, leading to a little bit of pneumoperitoneum or leakage of saline. So that can be a real irritation. Whereas if you just distend what is enough, then your port may enter right into the bladder. So this is one of the vesicoscopic reimplantation which we performed at a Pure workshop. This is done by my friend Dr. VVS. This is still one of the best videos I have. So this is what I was mentioning. So we railroad the sound from below, and then we pass the 5 mm trocar right into the bladder. But before you do that, you have to make sure that you fix the bladder to the rectus sheath and skin, so that it doesn't keep on retracting. So if you don't do that, it becomes a real messy operation. The bladder, once it starts leaking, there is a lot of collection of the water around it. So you cannot complete this operation. So that is what about it. But apart from that, once you have secured the bladder nicely, once you have got the trocars in place, this is a pretty straightforward operation, exactly like your open Cohen's reimplantation, where you mobilize the ureter, you make sure that you don't devascularize it, and then you close the hiatus, the muscle detrusor behind at the level of the, so that is the closure of the hiatus behind that ureter, and then you create a submucosal tunnel and cross the ureter across. So that is a submucosal tunnel being created, and then you cross the ureter to the other side, and then you fix it with the 2 or 3 sutures, and you always leave a double J stent. So that is a vesicoscopic Cohen's reimplantation. Now coming to some special situations, there are situations like duplex vesicoureteric reflux, where you will need a common sheath reimplantation, and there are conditions like refluxing obstructed megaureter, where you may have to excise the distal segment. Then there may be a diverticulum or ectopic ureter, where you may have to repair the detrusor beneath it. And there may be conditions like a megaureter, where you may need a tapering of the ureter. And then there may be combinations like a PUJ and a VUR, or a PUJ and a VUJ obstruction. I prefer to deal with the PUJ first, because that is a more proximal obstruction causing a higher pressure than dealing with the rest of the conditions like VUR or VUJ obstruction. Now, this is a patient with the ureterocele with vesicoureteric reflux we had. So this was an antenatally diagnosed duplex system with ureterocele, and that is a CT urogram done elsewhere. We don't do CT urograms, we would rather do an MRI. So this is a ureterocele prolapsing towards the urethra, causing bladder outlet obstruction. So we initially punctured the ureterocele just to relieve that obstruction to the bladder neck, and we thought that itself will take care of the situation. But later on, there was when we evaluated the patient, there was reflux on both sides. So both the ureterocele moiety as well as the other moiety was refluxing. So we need to do a common sheath reimplantation because the upper pole function was preserved. So that is the stay stitch. That is where you take the stay stitch between the common sheath. So this is a Poli-Turner Ledbetter type of reimplantation. So you lift the ureter, repair the detrusor defect below the ureteric ureters. So there is a nice detrusor closure there. Then you bring back the ureter and then place it in its position. I don't like Cohen's in this place because once you do Cohen, all three ureteric orifices will be on the right side. So that is about use of a Poli-Turner Ledbetter. Now coming to the types of tapering and tailoring, in those with vesicoureteric junction obstruction, you may have to taper the ureter. There are different types of ureteric tapering. We know the star plication or Kalsinski plication. One of the problems with these things is I really don't like these kind of taperings because they cause a bulk. Our aim is to remove an obstruction, and if we ourselves add to the bulk, and then the dilated system may not drain well. So I always prefer this excisional tapering if at all I do. So that is the excisional tapering which we do, and then reimplant the ureter. So primary megaureter, obstructed megaureter, I want to tell a couple of points about it. Usually it is managed conservatively with antibiotic prophylaxis in those less than 1 year old. Someone has to mute their phone, I think. Subhash, is it? Yeah, so usually it is a conservative treatment with antibiotics like in vesicoureteric reflux in megaureter as well. And in older children, refractory UTI, you can go for a tapered reimplantation. Usually they are 2 years, 3 years, so that the bladder is big enough. But if they are very small, like an infant with a recurrent urosepsis, so what do you do? So in this situation, I prefer to do a circumcision and then wait, maybe put them on antibiotic prophylaxis and see what happens to buy time until the bladder grows. Now, the options here are you can do a cystoscopy and double jet stenting to buy time. Sometimes the double jet stent goes, sometimes it doesn't go. If you can't do a cystoscopy double jet stenting, then in one of the option in a primary megaureter is to do a ureterostomy, and this ureterostomy has to be an end ureterostomy. So I will talk about it in the next slide. So coming to reimplantation, reimplantation of the megaureter in a small bladder can be a real problem, and it can be challenging. So there are different types of reimplantations proposed, called refluxing reimplantations, mini reimplantations, and lap reimplantations for this primary megaureter. I will come to that one by one. But before that, I'll finish off this ureterostomy. The point I want to make is a loop ureterostomy is not an apt operation in a case of a vesicoureteric junction obstruction, because when you do a loop ureterostomy, later on you may have to come back to do the reimplantation. So this kind of ureter, this portion maybe you have to excise it, and as you mobilize the ureterostomy, this portion will go. So this kind of redundant portion will eventually lose the blood supply, and that has to be discarded. So if you have a lot of tortuosity, like in this picture, you may be able to bring it down. Otherwise, you will have a lot of shortage here when you do a loop ureterostomy. So this is the best operation is to disconnect the ureter here at the vesicoureteric junction and do a end ureterostomy, so that the entire ureter is available for a future reimplantation. So that is what I will do, an end ureterostomy for in a patient with a vesicoureteric junction obstruction, if at all you have to do. Now, refluxing ureteric reimplantation, it is a method proposed for management of primary megaureter, proposed in the UK group. So what they did was, it can be done laparoscopically or open. they simply divided the ureter, ligated the ureter. They didn't go all the way up to this position. They just simply ligated it and then anastomosed it there to the bladder. So they joined the bladder at the dome and they didn't bother to reimplant it. So it is just a connection of that ureter back into the bladder. So it's like an internal ureterostomy. So they reported their outcomes, and then 3 out of 9 developed urinary tract infections, and 18 out of 19 needed an elective reimplantation later on. But still, they felt that this is a good technique because instead of having a ureterostomy, this diverts the urine inside, allows the bladder to grow, and later on you can always do a reimplantation safely when the bladder has become bigger. Now, this is one of the modification of that. It's a mini reimplantation which we proposed as a new technique. So here what we did was, like, this is particularly for infants where the small bladder is there. So we mobilized that ureter and then remove that narrow segment. But we make a small incision like a Poli-Turner Ledbetter and then close the detrusor for whatever possible, like 1 stitch or 2 stitch. Don't bother to make a real 4 to 5:1 tunnel, but even if it is a 2:1 tunnel, that is fine. And then bring back the ureter there. So that is a mini reimplantation, which is a 2:1 tunnel. And instead of doing a reimplantation without any tunnel, we thought with this is a better option. And then in our study, 12 out of 15 did not warrant a repeat procedure. Only in 3 they warranted, and all 3 of them were done laparoscopically, extravesically, buried in the later stage. Now, laparoscopic reimplantation for primary megaureter, a couple of different techniques have been proposed. So this is what I told you from GO's group. They have mentioned this modified Shanfield technique, where after excising the distal narrow segment of the ureter, they made a opening in the detrusor, like detrusor myotomy, and made an incision there. And then they made a small incision here, and then take a bite like this, and then push the ureter into it like a it's an interception of the ureter into that bladder. This is pretty much like what we saw earlier, like creating a nipple. So this is what they did. So lap reimplantation for primary megaureter can be a useful option, which we tried in a couple of patients. It worked well, actually. This is a 9-month-old girl with a gross hydroureteronephrosis and urinary tract infections. There was quite a bit of dilated system on CT as well as diuretic studies. So this is 5 mm umbilical and 2-3 mm ports have been inserted. That is the huge dilated ureter what you are seeing there. So we have not even gone all the way up to that bladder. So we have just the uterus and broad ligaments are there. We have not dissected all of it. We have just disconnected it and then tied the distal end. So the distal end has been tied off, and that is the megaureter which has been lying freely in the abdomen now. So the bladder is opened vertically. I mean, not vertically, in the sense obliquely, where you want to bury it. So we create a tunnel there. So that is a detrusor myotomy. It's not a huge tunnel. It is just a 1 centimeter ureter, 2 centimeter tunnel, like that. So that is where it is going to go. And the bladder is opened, the distal most part. So we take a bite into the one side of the bladder, then we take a bite into the ureter side wall, and then we go back and take a bite into the bladder. So this is a kind of a loop of a 4-0 vicral suture. And this patient is actually in lithotomy position, so we are able to put the stent via the cystoscope, and that stent has been passed over a guide wire into the ureter. We've done a C-arm just to make sure that the stent has gone all the way up to the thing. Now the ureter is shoved back inside, is shoved into the bladder. 2 to 3, not 2 to 3, like around half a centimeter of ureter is actually inside the bladder, prolapsing inside. And that ureter now, the tied, it has been tied nicely. And if possible, you can bury the ureter also here. So here, because we have made a 2:1 that incision in the detrusor, we go behind the ureter, we take a bite on the other side of the detrusor. As I said, if you know how to do the backhand driving of the needle, it's pretty useful in extravesical reimplantations. So this is a little burying. I mean, if at all it works, then you may avoid another reimplantation later on. So that is the ureter being aligned. The suture is taken from the other side to this side. It doesn't always have to be the needle which is brought onto the under the ureter. The suture also can be brought under. So this has been tied once. So there is just a single bite there in the detrusor closure. So that is the ureter, and that is the how ureter appears in cystoscope. At the end, we did a cystoscope. It looks like a small projection, like a bulge inside. Complications of ureteric reimplantations, early complications like a bladder spasm or hematuria, catheter blockage, stent-related problems. So these all are well known. Late complications, one and the things which we may really worry about is like recurrent vesicoureteric reflux or obstruction happening. The obstruction mainly happens because we do not take care of the vascularity of that ureter. The dissection has to be delicate, and the thickness of the ureter, the entire adventitia and the mucosa has to be kept. You dissect only the 12 days fascia. So if you leave the entire adventitia of the ureter intact, it doesn't cause obstruction. Now, failed reimplantation can be a challenge. Sometimes we do get patients where the previous ureteric reimplantation has failed and there is a shortage of ureter. In such a situation, you may have to do what is called a psoas hitch. So this is a condition where you hitch the bladder to the psoas muscle, and then the short ureter or these are the situations where that ureterostomy has been done, or the ureter, the distal portion of the ureter is lost. So you fix the bladder there, and then the bladder goes towards the ureter basically, and the ureter, the tunnel is created. The ureter comes into the bladder. Whatever possible, you make a tunnel and then close the bladder. Now, obviously, you cannot do it on either side. So probably only one side failed reimplantation you can do so as hitch. Now, sting procedure for failed Cohen, and that can be really handy. This is a video provided by Professor Ravikumar. So this is a patient who had a previous vesicoureteric reflux reimplantation done, and doing a sting in these patients can be really a boon, because you can avoid a complex redo operation. You have to ensure that you are injecting the right, the correct side. So in this patient, the right side has been refluxing. So that is the crossed ureteric orifice which is appearing on, towards the left. So inject it at the, it's not exactly 6 o'clock, it is around 5 o'clock of that ureteric orifice. So you put a, initially you put a ureteric catheter, check that it is on the correct side you are injecting, and then make sure that you also have not caused any obstruction to that. So that is a sting procedure in failed Cohen's reimplantation, which can be really handy in some cases. So that's about different types of reimplantation, different situations, and different problems we face. I will stop sharing here, and maybe I'll request Rasik to share some videos of his lap reimplantation, and after that maybe we can take some questions.
Okay, I'll show you one reimplant and Vesicoscopic, which we did few months back. This particular child had right obstructive megaureter with kidney function of 33% and recurrent urinary infections. So he came from interior of Maharashtra for the surgery. One of the doctor's friend's relative. So he underwent cystoscopy. Here, one question was asked: will you do cystoscopy in all your patients, Ramesh Babu, before
Not really. I mean, definitely I won't do a cystoscopy as it is as a separate investigative modality. If at all I do before reimplantation, but if I'm doing a Cohen's reimplantation in a bilateral vesicular reflux, I don't particularly do a cystoscopy. Whereas if I do an extravesical reimplantation, I'll do a cystoscopy and leave a ureteric catheter.
Okay. In this patient, MCU was normal. So this is the right ureteric opening. You can see there was some trabeculation, but child was otherwise passing normal urine. And looking at the left ureteric opening, that also looked okay. We'll just see in a minute. It was, of course, a little smaller than what we will like to see here. But there was no hydroureteronephrosis on the left side. So then we went ahead with Vesicoscopic Ureteric Reimplant using what you said, the similarly 5 millimeter 30-degree scope, 3 millimeter instruments. I could not put this 5 French feeding tube on the left side. So we are putting, I mean, we put on the right side and started mobilizing. So we put a stitch at the uretrovesical junction, and then using cautery diathermy hook, we make an incision all around, at least mark it, and then cut it with the scissors. And you want to keep this suture long because you don't want to lose the ureter, in particularly in case of bilateral ureteric reimplant. If you are mobilizing left side and if you have already mobilized right side, sometimes you can lose in the retroperitoneum. So if the suture is long, it becomes handy. So then you make it cut adequately. And the important thing is you need to go into the correct plane. Correct plane means you want to divide the detrusor muscles all around and you want to be on the ureter. So you can see now nicely that you have got the correct plane. So these are all detrusal muscles you will divide so that you can dissect on the ureter and you can go into the retroperitoneum. Again, in this particular patient, we did not add lot of redundant ureter like what Dr. Ramesh Babu showed in you one of the slides. Then when you don't have a lot of redundant ureter, you don't want to lose a lot of ureter while mobilization. Otherwise, you may not get the adequate length of your submucous tunnel. So whenever you use diathermy or scissors, you have to make sure you don't damage the blood supply. Now in this particular patient, we wanted to excise terminal 1.5 to 2 centimeter because it appeared to be obstructive megaureter. And as we go further, we'll see. So we are getting into the correct plane as of now. Once you are in the correct plane, then the dissection becomes much easier. Whatever the redundant ureter, it can be mobilized very easily without any problem. So we are still working into getting into the correct plane. And now you can see the ureter is free all around. And now you can do blunt dissection using your suction irrigation cannula or any other way which you like to do. There will be some tethering bands. You have to be judicious and make sure that they are not the blood supply, particularly of the ureter which you want to save. So we have mobilized 2.53 centimeter, and this is the extravesical portion which is coming into the view now. And then once you are extravesical, as I told you, the dissection becomes much easier. So that is what we can see over here. These are the bands. You have to be careful that they are not going to damage the blood supply. So we wanted, this was about a centimeter in size. So now we wanted to create the tunnel and we were not happy without any catheter in the left ureter. So that was the ureteric catheter which was placed. The uretrovesical junction or opening in the detrusor was not very wide. So we just made a small incision in the detrusor on the superior lateral aspect of the ureteric opening. And then you want to create a tunnel. So there are many ways you can create submucosal tunnel. We like to do with the scissor, whether it is open or vesicoscopic ureteric reimplant. So that's the scissor which is being used. And we wanted about 3 centimeter or so. The important thing is in your left hand, you should have bowel grasper. It is a very good instrument instead of Maryland. Maryland will cut through. It will tear the mucosa, but the grasper is less likely to tear and you have to be very gentle. Otherwise, it will tear whatever. So right now we have put the grasper even from the left side and dilated the tract little bit over there. The advantage of bowel grasper is a large blade. So that blade which is very large, it will give you very large tunnel. If you use Maryland, the length of the jaws is relatively less. The tunnel length will be less. So when the ureter is dilated and you want to accommodate without any compression of the ureter in the tunnel, then you use the bowel grasper. Then once you have dilated the tunnel adequately, then you should put, using Maryland, you can pull that ureter into the tunnel. Then you make the incision and then start fixing it. Here we did not take any bite with the detrusor to close the uretrovesical junction because it was snugly fitting. Otherwise, as Dr. Ramesh Babu said, you should close with whatever 2 or 3 sutures. Generally, we use 4-0 Vicryl, but if it is very small child, you may use 5-0 also. And this anastomosis, you have seen one suture is there. You need 4-5 sutures and you are done with it. So 1, 2, 3, and 4, 5, that is what you need. So once you have 2-3 sutures, you can cut off the ureter completely. Initially, you saw that we just cut little bit so that you don't lose the ureter again in the tunnel. So the 3 sutures are there, then we have cut it completely. And then you can put 1 or 2 suture more. In this particular patient, I have put the 2 sutures, but you can get away even with 1 more suture. So there are 4 or 5 sutures. Then you put a stent. Here the ureter is dilated, so you can put a large size stent, maybe 4.5 French without any problem. The length you have to select as per the size. Generally, what we like is age of the child plus 10 centimeters. That is the length of the stent what you need normally in any child. So that is the last suture which is being placed. And then you close the mucosa on the hiatus, the mucosa on the right side. So this suture is little bit shown extra. It is tricky to suture in a small area. This child was about 3 years old. So the bladder capacity would be roughly about 120 ml or so. So it's not easy operations doing vesicoscopically in a small child. You need to practice suturing in a small area. If you can do that, you can do vesicoscopic ureteric reimplant. And we like to have our both hands in the view while doing suturing in a small area. So once you have done that, then you can close this mucosa, and you close in such a way that the length of the submucosal tunnel has been kept adequately. That will be the last suture on the mucosa. Then what you do is, if you have 3 millimeter scope, you can change the 3 millimeters to 3 millimeter scope and put from the one of the side port, and it will help you in the removal of the ureter, which is quite large in size. Then you take out that ureteric catheter, put Foley's per urethrally, and then you can take out under vision and close that opening. So all these ports are out, and then we take out the ports. Now I will stop sharing, and we can ask the questions to Dr. Ramesh Babu. Virender, you want to start asking questions?
Right, sir. I'll start with the questions. And
Yeah.
before that, Dr. Ramesh Babu, congratulations on a very comprehensive session. We had about 72 participants on Zoom and about 710 of them on Yahoo. So that's a good number. And we have about 20 questions from those participants.
Great. Yeah.
The first question was from Dr. Akshay Kalavan, and he asked whether Paquin's rule refers to the external diameter or the internal diameter lumen of the ureter.
That is a very tricky question. I mean, what we can measure only is the external diameter. We cannot measure the internal diameter. So I suppose it is the external diameter.
Okay. The next question was from Dr. Ravi Ramadwar, and he wanted to know that for bilateral Cohen's reimplantation, is it better to have 2 separate submucosal tunnels, or is 1 single tunnel sufficient?
Whenever we try 2 tunnels, it eventually becomes 1 tunnel. So they both join together. It doesn't really matter. 1 tunnel is more than enough. The one point which I forgot to mention is the higher reflexing side is brought cranially. Because the trigone is a triangle, inverted triangle, the higher tunnel has got a bigger length, the cranial tunnel. So the cranial tunnel usually takes the higher refluxing site. If, for example, if the left is grade 4 and right is grade 3, I will bring the left ureter above and then right ureter below. But usually I bring it through the same tunnel. I don't have to bother about two different tunnels. That is possible only in somebody who is 8 or 10 years old. It is not possible in somebody who is less than 5 years old, because the trigone itself is too small, and then it's okay to be in both being in the same tunnel.
At the end, what we will do is we will take the opinion of Dr.
Yes.
S.S. Joshi and anybody senior if they want to give any insight about from their experience. Yeah, continue, Virender.
Right. So Dr. Chandrasekhar had an opinion on that. So I think we'll take that in the end as well regarding whether it's a single tunnel or two tunnels are good. The next question was by Dr. Vaman. I think you've already answered that, whether you need a cystoscopy in all cases. So we've already taken that question. So there were two questions regarding the technique of Poli-Turner Ledbetter. One was regarding the original technique by Dr. Chandrasekharan. And he asked that in the original Poli-Turner Ledbetter technique, the detrusor is not opened cranially, but extravesical dissection is blindly done from inside the bladder. What is your comment?
That's correct. That's correct. You put a right angle forceps or a hemostat at a higher place, and then go blindly to the place where the UO is, and then try to hook it there. So you do not know whether you are actually hooking the vas deferens also or other structures also. That is why that technique was not proper. And then with the modifications, we are now under vision doing it. So we are opening the detrusor like a book. And then you bring the ureter up, then you close the detrusor below that, and then close the mucosa over. So now there is no problem with the Poli-Turner Ledbetter.
Sure. So the exact same comment about the modified Poli-Turner Ledbetter was made by Dr. Senthil Ganesh as well. So we've taken his comment. Dr. Prakash Agrawal wishes to ask, what happens if you end up opening the mucosa during an extravesical reimplant?
Yeah, that's a problem. In the sense, it depends on when you open it. So if towards the end of your creating the tunnel, it usually gets opened when you are dissecting around the vesicoureteric junction. So you start opening from the top, and then you start creating the tunnel, and then those places usually doesn't get open. As you come closer to the vesicoureteric junction, sometimes it gets opened. You can put a small PDS suture there and close it, but it doesn't often stay. It really doesn't matter if you don't close it, because the mucosa will grow over it. But the only thing is, you should have completed the procedure. The bladder decompresses at that stage. So your nice creation of your submucosal tunnel becomes a problem if it happens much early during your dissection.
Sure, sir. So we had a comment from Dr. Manish Sachdev, he's our colleague from Bulgaria, as we were chatting with him, that during a vesicoscopic reimplant, if we take a bite via straight needle across a gauze and hold it outside, we can probably avoid using a fourth trocar. Do you agree with that? He's just suggesting maybe one. Fourth trocar.
We don't usually put 4 trocars. Rasik, is that right? We put only 3 trocars, right, for vesicoscopic?
Yeah, vesicoscopy, it is only 3 trocars. I think he was asking about extravesical reimplant.
Yeah. This is what. So I showed 2 different videos of extravesical. In the first one, there were only 3 trocars, but in the second one, there was a 4th trocar, which is placed just above the anterosuperior spine. So very close to the anterosuperior spine it was. So that was only there to hold that ureter above. So that ureter, if you hold it above, then your burying of that ureter into the detrusor myotomy becomes easier. So it is useful.
So he said that instead of the 4th trocar, you can put some needle and retract.
It doesn't always work that well, because it is not a simple stay suture which is holding it above. It has to be mobile. You have to adjust it, and then always the 4th port is useful.
Okay.
Awesome. Do I continue, Dr. Rashid?
Yeah, continue.
So the next question is from Dr. Madhu from Chennai. So there are several case scenarios that we've essentially been asked. One of them is from Dr. Madhu, who says that if there is an asymptomatic 8-year-old, the sex has not been mentioned, and if the ultrasound abdomen shows a small contracted kidney, a DMSA scan shows 28% function, but the patient is asymptomatic, should we operate or we should not operate since the patient is asymptomatic? And is there an age limit beyond which surgery is not needed for these asymptomatic patients?
You pass that comment on the sex, which is correctly a correct point. I mean, if it is a female, we have a slightly higher risk of them developing pyelonephritis during pregnancy. So persistent reflux in a female is a problem, and then we always tend to operate on them. Whereas persistent reflux on boys, you can argue that if there are no symptoms, if they are not having any more worsening of the scars, you can wait. So that you can argue it that way.
Okay. I think I'll take up the other case scenarios as well. The next one was put up by Dr. Miglani, and he wishes to know what is the ideal approach for bilateral primary vesicoureteric junction obstruction with bilateral hydroureteral nephrosis in a 10-month-old male. And there is no demonstrable VUR, so it's a primary VUJO that he's talking about.
Yes, we did discuss this case in the afternoon with Dr. Miglani. This is a bilateral vesicoureteric junction obstruction in a 10-month-old. So this is a small bladder and then megaureters, and this is going to be a tough if you do a reimplantation. So I will do it in stages. Like for example, I will put them on antibiotic prophylaxis first, maybe do a circumcision. This is a boy, I presume. So we'll do a circumcision, and then in some of them, we can pass a stent across, like a cystoscopy and stenting is a useful option. If we can stent them for and then by time, we can always do that. But the only thing we have to be aware is when we remove the stent, it becomes obvious that they are obstructed. So this is only a buying time. So stenting may not be a permanent cure. Now, anticholinergics have helped in some children with these problems. So there are 3 different options here. So one is to do a circumcision and antibiotic prophylaxis, stenting and antibiotic prophylaxis, maybe add anticholinergic also, but I won't do a reimplantation yet.
Sure. So there were actually 2 questions on the role of anticholinergics since you've mentioned those. One was from Dr. Balamurgan, and he specifically asked what is the role of antibiotics in the initial conservative management. So would you like to describe more case scenarios where anticholinergics are helpful pre-operatively?
Now that they just brought up, we have to talk about antibiotic prophylaxis. In vesicoureteric reflux, the role of antibiotics is now there's a paradigm shift from using more antibiotics to using less antibiotics these days, because the evidence is like the antibiotic prophylaxis does not necessarily help in a way to prevent UTIs and scarring, and they actually may harm in the form of having a resistant bugs. So these are the kind of theories which is coming up. So people are questioning the basic tenet of antibiotic prophylaxis. But having said that, the AUA guidelines says that any dilating reflux, that means from 3 to 5, it is worthwhile putting them on antibiotic prophylaxis. Whereas if it is grade 1 and 2, definitely we won't put them on antibiotic prophylaxis. So that is where we stand. If it is a grade 3 onwards, we put them on antibiotic prophylaxis. At least in India, we have to put them on antibiotic prophylaxis. Now, the reason to put them on antibiotic prophylaxis is we say that breakthrough infection is an indication for reimplantation. When they are not on antibiotic prophylaxis, where is the question of breakthrough infection? So there is at least to know that they have a breakthrough, or they have at least they are compliant with some medication. So from the grade 3 to 5, we put them on antibiotic prophylaxis. We sometimes even go to the extent of giving 2 different antibiotics. Like if they are not, if something is not tasty, then we change it and then give another one for 1 month and then go back to 1 month. And only after trying that for the first 1 or 2 years, then we go for a reimplantation from the 1.5 years onwards. So we do have a role for antibiotic prophylaxis in dilating reflux.
So to this, Dr. Chandrasekharam is commenting that an infant's antibiotic prophylaxis is recommended for all grades. So that's a comment that he's made. And
fair enough.
Yeah. Dr. Ramesh, the question.
Sorry, I can't hear you. Virender, you're muted.
Virender.
Yeah.
No, the question that Dr. Balamurgan had asked was the role of anticholinergics, not antibiotics, in the pre-op management of these patients.
Right. See, empirical anticholinergics are being tried by some people. This is not my piece of cake. I don't do that. I put them only if they have a specific voiding dysfunction symptoms, like if they have bowel bladder dysfunction, obviously I have to treat the constipation part. and then treat the bladder dysfunction part, maybe with anticholinergics. Empirically, if somebody without a bowel bladder dysfunction or such a history, I won't put them on anticholinergics preoperatively.
Okay. And how about post-op? Because that was a question asked by Dr. Manoj Joshi, that what is the role of post-op anticholinergics? Are there some specific case scenarios where you would recommend using them for some time?
After reimplantation, both Cohen as well as extravesical, the bladder itself doesn't contract that much. That's what I believe, because in Cohen's, you have opened the bladder and closed it, so the chances of it going for that voiding dysfunction, not voiding dysfunction, the hyperactive contractions or whatever overactive bladder kind of situation is not there for at least the next 2 weeks or 3 weeks. In extravesical, you actually worry about retention. So in the post-operative period, at least in the immediate post-operative period, I will not put them on anticholinergic. But after a period of 1 month, maybe you can start them back on anticholinergics, or if you have feeling that they have got frequency urgency, you can put them on anticholinergic. But in the immediate post-operative period, I will not put them because you risk retention.
Sure. So going back to the question that Dr. Miglani had asked, he has commented again that if we stent that VUJO patient, will stenting not cause increase in infection?
Yes and no. I mean, stenting can cause infection of the infection, but at the same time, you protect the kidneys. So you're going to keep them on antibiotic prophylaxis, and you're going to do a circumcision at the same time. So, you know, it's a bargain.
Sure. So going back to the case scenarios, there's another one put up by Dr. Anil Kumar, who's asking if there is a 5-month-old female with grade 5 reflux and a 30% function on DMSA scan, what are the options that we have for management?
5-month-old.
5-month female, grade 5 UR, 30% function.
If there is the risk of urosepsis, then you may have to do something. But is there any urosepsis? If it is just a reflux with one episode of UTI, I would still treat them on antibiotic prophylaxis and wait for them to at least repeat the MCU at 1 year and then see what happens. There are situations like we end up we have a severe urosepsis in a 3-month-old, 5-month-old, when you have a role for a diversion, but not usually.
Sure. And then another question by Dr. Anil himself, that during extravesical reimplantation, how would you be sure that you're not blocking the ureter? And is pre-op stenting helpful in these lab extravesical reimplant cases?
Extravesical reimplantation, when we open the detrusor, we make sure that the bladder is half full or at least 3/4 full, so that the mucosa bulges. So when the mucosa bulges, you know that there's a small kind of dissection happening there between the mucosa and the detrusor. So it's like the detrusor is elevated a little bit, not completely, but the detrusor is it becomes wide like a ellipse. So when it becomes like an ellipse, you know that when the ureter goes in, you can close the detrusor over it. More than that, the length of that incision also has to be adequate. If you make a very small incision, obviously that width of that ellipse is not great, so you risk of obstruction. But as I do, I prefer to leave them on either ureteric catheter or a double stent for the same reason, because at least for 1 or 2 weeks, if it is ureteric catheter, I know that I'm not tightened it too much, and then once it has healed, when I remove the catheter, that ureteric catheter comes out. So that is my practice in extravesical reimplantation. Some people leave a double stent. That's fine. You can leave a double stent to sleep comfortably and remove it after 6 weeks. It's even better.
Noted, sir. I think just on a lighter note, quite a few people are amused by how your background, of course, that gets asked in every meeting. So Dr. Manoj, Dr. Akshay, Dr. Suhit, all of them. Do you wish to share a secret with them, sir?
There is no secret. There's a virtual background, which is option is available in the settings. You go there and then fix it. If it is an Apple computer, then it asks for a green screen. But I am using only Windows, so it doesn't ask me for a green screen behind me. Rasik, any points you want to add on Vesicoscopic reimplantation?
I think after your questions are over, one person is asked Dr. Yazi about how to put the ports. So I'll take that.
Okay. So we'll take that in the end. I'll continue with the questions in the meanwhile, sir. Dr. Kiran is asking, can you enlighten us about more techniques of ureteric reimplantation other than those you mentioned? He's asking those for exam purposes specifically, and he's given a scenario whether classification of the position of ureteric opening on cystoscopy and what is its implication in selecting the type of repair.
As I said, this cystoscopic assessment of the ureteric orifice is more of an academic exercise. Doing a cystoscopy in a case of a vesicoureteric reflux and giving a GA for that alone, I really don't agree to that concept. You can do cystoscopy before a reimplantation if you have decided, but for diagnostic purposes, like to select a case based on how you do, I don't do a diagnostic cystoscopy at all. If I do a cystoscopy, it's either a part of a sting procedure or a part of just before a reimplantation after I made a decision for intervention. So the site of the opening, the how it looks like, it really doesn't influence my decisions. The decisions are made on progression of the renal scars or worsening of the UTIs, like it becomes more and more intractable UTIs, febrile UTIs. That's what decides me, not the site of the size or shape of the ureteric orifice.
Sure. So that is about the indications, sir. Dr. Balamurgan, in continuation, was also asking that between the different techniques of ureteric reimplantation available, how would you choose a particular technique for recurrent VURs? Given that there are so many techniques, how would you choose? Is it just your comfort or there are other factors that you would take into consideration?
For a recurrent VUR.
Or recurrent, that's what is written, recurrent reflux, yes.
Yeah, see, as I was discussing, in a case of a recurrent VUR, a sting is a good option. It avoids a difficult reimplantation. Then the second option, which I will personally feel, is like you do the laparoscopic extravesical. You make an incision in the detrusor and then bury it. So that is another good option. But if there is an obstruction also, like for example, after a reimplantation, there is an obstruction as well as a reflux, then you cannot do anything. You just have to close off that stump, dissect the ureter outside extravesically, then you create a new tunnel, like what I showed the picture, combined extra and intravesical reimplantation. So that's what you have to do. Sometimes there is a shortage of length. You may have to do a psoas hitch in such situations. So the recurrent redo reimplantations are tricky business, and you have to be aware of these modifications like a psoas hitch as well as the combined extra and intravesical reimplantation in such situations.
Sure, sir. I think we spoke a bit about circumcision, but Dr. Munisami Raghavan was specifically asking whether circumcision has any role in reflux cases. Not UTI specifically, but whether circumcision is useful in vesicoureteric reflux. That's the question.
I am a proponent of circumcision. So all my patients, whether they get a pyeloplasty or reimplantation, I simply ask them, do you want a circumcision? Because I'll do it anyway, free of cost. So they get buy one, get one free offer. But circumcision does prevent UTIs. It is well known, particularly in VUR. This is an option in infants. In infants where we want to avoid reimplantation, a circumcision is an option. You can do a circumcision. If you do a circumcision, obviously you can do cystoscopy to look at the UO to see how wide it is. But again, it's not going to let you decide what you want to do. You can do a cystoscopy circumcision, and then maybe that is an option in an infant with VUR.
Okay. The next question is by Dr. Madhu. Why not a Sober's ureterostomy for megaureter rather than an end ureterostomy?
Yes, this is you have when you do ureterostomy, you risk a shortage of ureter. That is the only problem. There is a distal end which you need for mobilization. This is a bit like a colostomy for imperforate anus. If you do a very low colostomy, then you cannot pull through. It's exactly like that. If you do a high ureterostomy pretty close to the kidney, then you probably are okay.
Okay. And how do you manage post-operative complications after vesicoscopic reimplant, specifically leak from port site? That's a question put up by Dr. Akshay.
See, the port site, I think Dr. Rasik is going to talk a little bit on the port siting as well. The siting of the ports in vesicoscopy is very crucial. You have to hitch the bladder to the apparatus and maybe the skin also. And then you have to make sure that it doesn't slip as you put the port in. And at the end of it also, you have to make sure that you have closed it, at least with one stitch. So these 2 or 3 things are little time consuming actually. They may be taking equal amount of time as your vesicoscopy itself, because sometimes putting the ports takes around some 20 minutes and then closing the bladder takes around some another 15-20 minutes. You have to take the time, otherwise this vesicoscopic reimplantation can run into trouble. Sure, so Rasik, I want you to add on that.
Right.
Hello. So yeah, I think I'll just say this, the port insertion, like what Dr. Ramesh Babu said. Basically, there are 2 techniques, Dr. Yazid, to put the ports as of now. One is under cystoscopic guidance. You put a scope and then you put a U suture or loop suture, 2 of them, and in between that you can put the trocar in. So this is done by a lot of people. In India, we do what Dr. Mohan Abram has Mohan Abram's technique, where we put a ureteral sound and push the fundus of the bladder, urinary bladder over the skin. So if this is the abdominal wall, the ureteral sound will push it up. Then we will make an incision on the skin. Before, in fact, once we feel, then we make an incision on the skin, excise subcutaneous fat, make an incision on fascia. Once you do that, the bladder with the sound will come out. So you take a stay suture in the bladder and then make an incision, then you put your port. Now port should have, depending upon the width of the abdominal wall, you guard your port by using finger of the glove and put it on that. So it will not slide in more. And then you fix the port. You put a purse string suture around if you want, so that there is no leak of CO2 around the catheter from the bladder. And it takes time. In fact, in my first case, I could not put the ports in, and then I had to consult Dr. Mohan Abram, Dr. Chandrasekharam, who had more experience, and then they gave me all these tips, and then we started doing that. So it will take time, and at the end, again, the closure will take time. And once you have made the incision, you suture that after you make an incision, detrusal mucosa with the skin, so that you don't lose the bladder. So this is a technique which we use. Now you can continue, Virender.
Right, sir. I think we have a few more questions left, so just to hustle up with them. There were 2 questions by Dr. Kamal Kant, and he's asking, how do you decide whether to taper or not to taper the ureters while reimplant? And if you have to taper while doing a laparoscopic ureteric reimplant, would you wish to deliver the ureter through one of the ports, maybe the umbilical port or some other port for the tapering?
Now, the tapering is decided based on various things, but usually you know the diameter of the ureter. If it is so huge and then you feel that the tunnel is not going to be enough, then you decide, looking at the vesicle with the VCUG picture, that and the patient size, you will know by looking at the VCUG and the patient size, this is not going to be enough. The ureter is quite wide, the trigone is so small. So you will know before the surgery starting itself that you probably know that this particular case needs a tapering. Now, tapering during an extravesical reimplantation is like you can deliver it through one of the ports, taper it, and then join it back, put it back in, put the port back in. It's much easier said than done. Tapering during a vesicoscopic reimplantation can be really tricky. I have not done it. So that is almost I have not done it, so I cannot comment on that. But tapering, we should be able to decide before we do it.
Okay. So regarding the tapering, I once heard Dr. Mohan Gundati mentioning that he almost never tapers any of the ureters, irrespective of the diameter. And
Yes. So this is about, I wanted to tell you this. I didn't tell this. Now, tapering for, the purpose of tapering is to prevent reflux, right? So in a case of a vesicoureteric reflux, for example, in a grade 5 vesicoureteric reflux with the megaureter, I would personally taper it because my primary aim is a prevention of reflux. Whereas in a case of an obstructed megaureter, my primary aim is to relieve the obstruction and then restore the kidney function. So for me, tapering in those situations is less of a priority unless the ureter is really huge. In fact, this obstructed megaureter tapering is quite a questionable thing. A lot of people don't taper. A lot of people don't bother that 4:5 ratio of a tunnel. Some people don't do a tunnel. Some people do a small tunnel. So some people taper. Some people don't taper. In a vesicoureteric junction obstruction, your main aim is to relieve the obstruction. Whereas in a case of vesicoureteric reflux, you have to prevent reflux. So you have to taper if it is huge megaureter. I'm sure there are a lot of other opinions here. There will be difference of opinions, but this is my view.
No, sir. So one of the last questions is by Dr. Manoj Joshi, and he wishes to ask, what is your follow-up protocol to assess the improvement in reflux, scars, and function of the kidney?
Yeah, so this is something which is important. The patients following a reimplantation, the follow-up protocol is like if we leave a stent, we remove a stent after 6 weeks. Most often we don't leave a stent, in which case we are fine. We do an ultrasound at 3 months. We do, I prefer a DTPA scan at 6 months because it achieves two purposes. And I give I tell them specifically to do the DTP at the beginning, and then at the end of it, ask the child to void, and then do a voiding study, and then see whether the count on the kidney is increasing. So this is a combination of a drainage study as well as a reflux assessment. So this is something which I prefer at the age of 6 months to 1 year, whenever they come for follow-up. Now, whether I repeat the MCU, I don't particularly repeat the MCU because it's quite a traumatic procedure. There are people who always repeat an MCU to look for a resolution of reflux. But if they are not developing UTI, I'm okay with an indirect cystogram.
So there's another case scenario put up by Dr. Shama. She says that in case of obstructing ceco-ureteral seal with ectopic ureter, causing bilateral hydroureteral nephrosis in a neonate, which is not decompressing with cystoscopic incision, what will be your approach?
That is a unilateral ureterocele, right?
Well, she's mentioned with bilateral hydroureteral nephrosis.
There we go. I'll refer to Rasiksha. Because that is a tough situation.
It is unilateral probably, so you should.
Yeah, it is unilateral probably.
And ureterostomy.
But when you do a proper incision, why will it not decompress? It should decompress because often ureterocele incision is the primary treatment to decompress. It should decompress. I think they should do another cystoscopy and try to decompress it. Okay. That is the easiest thing to do in a little baby rather than do anything heroic.
Okay.
So one last question was by Dr. Arvind. He says that during extravesical reimplantation, like laparoscopic or robotic extravesical reimplantation, he's specifically referring to Dr. Mohan Gundati's U-stitch. So Dr. Gundati has described the LUAA technique for his robotic reimplant. So Dr. Arvind is asking about the U-stitch that he takes just to anchor the ureter in the beginning. Do you use the same, or what is your comment on that?
Yeah, see this advancing of that ureter with one particular stitch at 6 o'clock has been part of this extravesical reimplantation, both open and open as well as this laparoscopic and robotic reimplantations. Now, this particular stitch can be really tricky in the sense when you take that stitch, you may take it from some of the innervations and then you may damage it. That is where the innervation is. The innervation comes at 6 o'clock. So if you take a stitch there to advance it, you may tie them. I don't know. I particularly don't like it where you use during laparoscopy. So what I do is I said that the incision goes like an inverted Y. right? So when you take an when I take the first bite, the first bite is from the medial side of the Y, then it goes a little higher in the ureter, and then takes again the lower part of the Y, the the lateral side. So when we tie it, automatically the ureter comes down, like it migrates. So that a particular stitch is a quite thickness of the ureter, which moves it further down and then anchors it. So this particular stitch is always good when you take it first. This is why taking the suture from bottom to top is always better than taking it from top to bottom in extravesical reimplantation. It may make life easier to do it from top to bottom, but you may miss that crucial stitch, which is the first stitch, which advances the ureter.
Yeah, at this point, can we take opinion of Dr. Ravi Kumar before we conclude the session?
Right, sir.
Because it's almost 1.5 hours.
Yeah.
Dr. Ravi Kumar.
Yeah.
Yeah. Okay, can you give some tips from your side, from your experience?
Hello, are you able to hear me?
Yes, sir.
We can.
Hello?
Yes, sir.
We can hear you, sir.
You have to unmute yourself.
He's unmuted, sir.
Yeah. No, not yet.
No.
Yes, sir.
Hello?
Dr. Ravi Kumar.
Are you able to hear me?
Yes, sir. We can hear you.
You can hear me, yeah. No, I think everything is completely covered. I mean, exhaustively covered. And then I just wanted to add the question by Dr. Madhu, a girl child who had reflux at 8 years of age. Should it be operated or not? See, if you don't operate on them, a lot of reports say that you can get a preeclampsia 3 to 4 times higher in a child who has become pregnant with a reflux. And then incidence of urinary tract infection is also quite high. And then incidence of hypertension is also high. And therefore, it's mandatory that every girl child who has a reflux must be made non-reflexing stage. I mean, that is the very important point in that. Now, I think rest of the things are all covered. The only thing is, last urology conference that was held some time ago, a lady from Sheffield, for all these obstructive megaureters, she has used a balloon dilators. And then by repeatedly increasing the size of the balloon dilator, followed by stent inside, she said more than about 70% of the obstructive megaureters did not need any surgery. I mean, I don't think any one of us are doing that. Neither we have the resource to have balloon dilators. So, am I audible to you?
Yes, sir.
Yeah. I mean, I do not know any one of us have this balloon dilators do that. By that, even a very small child, say about 4 months, 5 months, you can do the balloon dilator and put a stent, remove the stent and use a bigger dilators. And ultimately, nearly, I mean, surprisingly, she said nearly about 70% of them, they did not need surgery. And these are the things I just wanted to bring it to your notice. The one slide I showed you, which was shown in the beginning by Dr. Ramesh, is a slightly modified procedure which I do for extravesical reimplantation, where you make an incision, a small incision above and a small incision below, and then make a submuscular tunnel, like what you do in a submucosal inside the bladder. You do the submuscular tunnel and then bring it down. So the advantage is you don't cut the bladder, and subsequent probability of a neurogenic bladder is prevented. Now, if you're doing a bilateral reimplantation extravesically, this technique will prevent you from having a neurogenic bladder. I don't know whether you followed what I said.
Yes,
I
sir.
mean,
Yes, sir.
incisions above and incision below. Small transverse incisions are made. The mucosa is stripped. I use the back of the handle of the knife between the muscle and the mucosa and push the mucosa down well so the ureter lies without any obstruction, and bring it in the submuscular area and then make an anastomosis low down so that there is absolutely no incision on the bladder at all and the vertical aspect. And some of you can try that and then tell me whether it is feasible, technically feasible, or this one. Thank you very much for asking me to speak.
Thank you.
Thank you, sir.
Dr. Joshi is still here or left?
No, I think he left.
Okay.
Anyway, I think we will conclude the session, and before that, Ramesh Babu can give some remarks.
Oh, I think it was a nice to be with all of you and then share the experience, and then so I think we've covered almost